that a health decision maker is really thinking about when deciding whether or not to adopt or implement an intervention are things like, what health outcomes matter most to me in my community? What resources do I have? Essentially, what is my budget? And how much staff do I have? How much materials do I have? Can I ask folks not to have side conversations? I'm sorry, it's a little distracting. Okay. Which interventions are effective in real-world settings? What is their reach and impact on inequities? What do we implement? How do we implement and sustain these interventions? And then how much will it cost to implement these interventions in the short and in the long term? And then finally, how does this intervention compare with existing interventions we already paid for and or other alternatives we could consider implementing? Does the incremental benefit, am I finding that incremental benefit to be enough to justify the additional costs required to adopt the intervention? So these are really some key questions, and the last two kind of bring us to the cheaper part of the quote we just got reminded of. In assessing, is what we're doing kind of optimally using resources. So in economic evaluations, we often compare multiple interventions simultaneously to estimate which interventions provide the greatest value. We can assess different time horizons, so we can look, if we implement our intervention today, what is going to be our balance of costs and returns over a short period of time or over, years and years. And those can yield very different bits of information, especially as a pediatrician, we're often thinking of longer time horizons for our returns. And the methods differ based on the consequences that we're really interested in. We'll talk briefly through these three different methods: cost effectiveness analysis, cost utility analysis, and cost benefit analysis. I get this question all the time, what's the difference? And people tend to kind of conflate some of these terms, so I just want to take a second to remind everybody. So cost effectiveness analysis is when we're essentially just comparing costs to some effect estimate. It's most useful when considering a limited range of options within a given clinical field. So, for example, if I'm interested in treating hypertension, my effectiveness measure might be blood pressure reduction. If I'm interested in asthma, I might be looking at episode-free days. HIV, I might be looking at AIDS-free life years. And then if I'm kind of looking at colorectal cancer screening, I might look at cases detected. So the challenge can be, what if you are a decision maker interested in multiple conditions or multiple outcomes, which is often the case if you're kind of running a healthcare system or you're running your government payer trying to decide which programs to fund and invest in. You're often kind of working with multiple interventions that target multiple different interventions, or you might have a complex intervention that is actually trying to target multiple interventions. So that's when we kind of turn towards cost utility analysis. And some people will just go ahead and call these cost effectiveness analysis. So you'll hear cost effectiveness analysis used to describe cost utility analysis, but technically when you're looking at utilities, such as quality adjusted life years as your outcome, instead of some more kind of discrete measure of health, it's a cost utility analysis. So your effectiveness is measured and kind of combined into a single composite summary outcome, such as qualities or DALYs. Qualities are quality adjusted life years, so it's essentially asking what is the quality of life experience for each extra year of life gained from an intervention. So if I am adding a year to someone's life, but that year is spent in a lot of pain or anguish, then that intervention is going to be valued differently than an intervention that creates another year of life in perfect health. The flip of that is disability adjusted life years, which in some cases might be used. In these, we can get into this more if folks are interested, but essentially these are they're different methods to sort of measure this utility, and they're kind of commonly used survey measures that can be assessed and used in a cost effectiveness analysis, assessing health-related quality of life. So final one I want to briefly touch on, because you'll see this as well, and sometimes people use this term interchangeably, but cost-benefit analysis actually is quite different than cost-effectiveness analysis or cost-utility analysis. Those two are essentially the same, just the outcomes is a little bit different. Cost-benefit analysis actually is different in that it requires program consequences to be valued in monetary units. The primary goal of CBA is to identify projects with positive net benefits. So if we have an intervention, rather than kind of making that ratio of cost per unit improvement in quality adjusted life years, we're instead actually trying to come to a dollar value, and we're assigning some monetary value to whatever our health outcome is. So obviously, it can be difficult to assign monetary value to health outcomes like a year of life or an HIV diagnosis, and there's a lot of ethical challenges with that. So, and we'll say this is less commonly used, but you will see it done. All right, so that aside, we're going to mostly focus on cost effectiveness analysis and cost utility analysis for the rest of this part of the conversation. And I want to pose this question. So is the intervention cost effective? I feel like we all hear this all the time, and we hear folks, saying that this intervention is cost effective. So if there's one thing that you take away from this session, I would love for that thing to be that the answer to this question should never just be a flat yes or a flat no. It should always be contextualized, right? Unless it's cost saving, right? If you have an intervention that you're implementing and it costs less to implement the intervention than the healthcare savings that you're going to get as a result of implementing the intervention, then you can say it's cost saving. But you really never want to describe an intervention as cost effective unless you're comparing it with something else. So are you comparing it with status quo? Or are you comparing it with some other intervention? Or are you comparing it with some threshold like willingness to pay, which there are some countries that have established thresholds of what a nation or a government payer is willing to pay for an additional unit of health, like quality adjusted life years. So there are some standards out there. So we have some tools to assess and kind of think about cost effectiveness, and so I'm going to focus on the two most commonly used, which are the incremental cost effectiveness ratio and the cost effectiveness plane. So the incremental cost effectiveness ratio is literally exactly what the name says. So you're looking at the delta cost, right? The cost of the intervention compared with the cost of the comparator intervention, the next best intervention, and then you're putting that over the difference between your effectiveness of the intervention and the effectiveness of your next best intervention. So what's really neat about this is you're not just looking at cost or effectiveness in a vacuum, which we are often guilty of doing. You're actually making that comparison and looking at the marginal or incremental benefit as well as the incremental cost. So you can imagine if we have an intervention that is incredibly expensive to implement, but only makes a small improvement in effectiveness. If we look at that intervention in a vacuum, we might determine that it's something worth pursuing. But if we compare it with a less expensive intervention that kind of slightly worse effectiveness, we might actually choose to forego that more costly intervention. So the cost effectiveness plane, along with the incremental cost effectiveness ratio, can be a really helpful tool in sort of comparing interventions. And this is Steve Boardmaker, who I worked with as part of a big childhood obesity cost effectiveness project, developed this very simple figure. So I've asked for his permission to use it because I think it just captures the cost effectiveness plane so perfectly. Essentially, a cost effectiveness plane is a graph. And on the y-axis, you have the difference in cost. On the x-axis, you have the difference in effectiveness. And so you'll see the pluses and the minuses. So in the top left corner, you have the interventions that have the highest costs and the worst outcomes, right? Both are the costs are in the plus, and the effectiveness is in the minus. So those are your worst case scenario, really not ideal to pursue, but if you look at kind of the real world, there are actually interventions that we pursue that fall into this category. One example is like diet pills that are well established that as not being good for anyone's health and have costs associated with them, and can actually cause harm, yet folks are shelling out money for them. In the bottom right corner, we have interventions that are lower in cost and yield a better outcome. So those are our ideal case scenario, right? And an example of that would be like a tax on sugary beverages, where you're improving health outcomes and then you're bringing money into your government through the tax. So both of those are helpful. And then, majority of the time we're falling into that higher cost, better outcome category. If we're thinking about an intervention, it probably has some demonstrated effectiveness. And so, so that's just to give you a quick sense of the cost effectiveness plane. And then let's kind of get into this comparative piece, right? So the center of the cost effectiveness plane is our kind of origin or our status quo. If we are do nothing sort of state or standard of care, we already described the y-axis is the additional expected costs of each strategy with respect to the status quo. The x-axis is the additional expected effectiveness or utility, if we're looking at qualities, produced by each strategy with respect to the status quo. And so when we're looking at this, we want to do some assessment and some elimination. And the first thing we want to eliminate are strategies or interventions that are dominated by other strategies. And that's kind of an economic term to reflect strategies that really just don't make sense because they're either higher cost and less effective than other strategies, or sort of fall outside the range of an optimal choice. And so some examples from this figure are, if you look at the origin point O, you can see it's dominated by E and H. It's dominated by E. And then point H is dominated by I. If you look at, so for example, O versus E, E is more effective, but saves costs, right? It's down the cost of that factor. For H, you have I that's more effective, but really pretty close in cost. So we essentially rule those out, and then we draw a line between the interventions that remain, that are not dominated, and that becomes what's called our cost effectiveness frontier. And the cost effectiveness frontier is where we essentially want to play in determining what interventions to pursue and what not to pursue. And whether we have information about a willingness to pay threshold or we have a set budget that we want to optimize, we can kind of use this figure and this cost effectiveness frontier to choose which interventions we're going to ultimately pursue. Okay, I know that's a brief summary, but definitely let me know if you have questions on this. So that said, I want to briefly touch on some limitations of cost effectiveness analysis in implementation research. So cost effectiveness analysis, as I mentioned, you can play with the time horizon, and often it's used to look at longer term economic benefit, but usually it doesn't necessarily look at implementation costs. A lot of times economists will actually leave out those sort of implementation costs like training or development of materials and tools that sort of are necessary to launch an intervention, but aren't necessary to necessarily continue an intervention. As implementation researchers, we're often really interested in those things, and implementers are also very interested in those things. Cost can be a major barrier to implementing evidence-based interventions, and intervention and costs associated with implementation, like labor, materials, technical assistance, are often more important to policymakers and organizational leaders than effectiveness. And so a potential method that can help with that is what's called budget impact analysis. This is another type of economic evaluation used to assess expected short-term changes in expenditures for a healthcare organization or healthcare system after adopting a new intervention. These I'm going to call it BIA for short, provides essential information for healthcare administrators and payers about the affordability and feasibility of a new intervention. They can the results of a BIA can be used for budget and resource planning. So comparing the two, BIA versus CEA, BIA's usually, budget impact analyses usually don't require comparison intervention. And that's really, we talked about that many times, right? I hope everyone got that point about cost effectiveness analyses. You always want to have a comparator. But for budget impact analysis, it's much more descriptive. You just want to assess how much does it cost to implement this intervention in the real world and sort of collect that descriptive data. It typically involves just a comparison to, what were you doing before and how much are you additionally going to have to invest. It doesn't require effectiveness data. You don't have to make that ratio. It's really just focused on the cost. It can be conducted alone or alongside a cost effectiveness analysis. And I'll say my team typically does this alongside because, especially in the initial phase of the trial, we're collecting this cost with the hope that we have an effective intervention where we can do a cost effectiveness analysis. And so you might kind of put out this budget impact analysis in the early phases of a trial involving a cost effectiveness analysis. Both budget impact analysis and cost effectiveness analysis should be conducted when reasonable evidence of potential efficacy or effectiveness of an intervention exists. And this is an interesting point that some folks might disagree on, but in my opinion, this is, if you're thinking on that spectrum that we talked about, I think it was yesterday, yes, I think it was Donna's talk where she talked about kind of efficacy to effectiveness, to hybrid designs, all the way to like a pure implementation study. I think budget impact analyses and cost effectiveness analyses probably fall somewhere in that hybrid range, and probably in the kind of hybrid type 2 and beyond range, because they take a lot of time, effort, and expenditure, and if you're not fully certain about the efficacy or effectiveness of an intervention, it probably doesn't make sense to invest a lot of resources, time, and effort from your team in assessing these cost outcomes. This should be more when you're kind of getting close to the point of thinking this intervention is ready for broad implementation. But folks may have different opinions on that. So key elements of a budget impact analysis. It's most valuable when an intervention is being translated from research into practice or scaled out. It involves estimating costs associated with the interventions of components, changes in staffing, for example, use of technology, changes in the number of patients receiving the new intervention, among other things. It also involves estimating short-term savings. So, by having a community health worker deliver a component of the intervention compared with a physician, you might actually have some short-term savings compared to status quo, and that's appropriate to describe. Your end result is to determine the total expenditures associated with adopting a new intervention, and they're always conducted, and this is a bit different from the cost effectiveness analysis, we'll talk about that. The perspective of assessing costs is always from the organization or the health system that's going to be implementing the intervention. So that's a good segue into talking about assessing costs of interventions. And so we often tend in cost effectiveness analysis to really focus on this high level sort of modeling and assessment of the ICER and the cost effectiveness claims, but there's a whole methodology to just even estimating the cost of an intervention. And I want to emphasize to everyone that this requires rigor, time, and effort. And the best costing work is actually typically mixed methods involving surveys and interviews and kind of deep exploration into the processes and costs associated with an intervention. And there's a few different approaches that people tend to take. So there's a gross costing approach and a micro costing approach. And they're sort of considered two ends of the spectrum. Sometimes you'll hear this referred to as top-down for the gross costing versus bottom-up costing. And this is where gross costing is, I know that the total budget of my intervention was X amount. And I'm going to, from that, parse out what I think the different components approximately fall into for the total amount. Sometimes in the US, very commonly people use administrative data and payments to try to estimate what costs are from that kind of a top-down approach to get to the smaller units that you're interested in. A micro-costing approach is considered to be more rigorous and a bit more accurate because it actually involves measuring the incremental components of your intervention. So assessing time spent doing various activities by your staff, exactly how many pieces of colored paper did you print, how many how much time was spent putting a mailing together, all of those very specific details. And the most rigorous is considered, approach to costing is considered to be prospective. So you're setting up surveys and tools for your team to kind of collect information about how much time and materials, travel, and other costs that they're incurring as they go. There are downsides to microcosting, and the biggest one is that when you do a microcosting approach, you tend not to factor in inefficiencies. So, folks are kind of counting their time spent preparing mailings. They may not, it looks like my timer stopped. So I just noticed that I've had 15 minutes for a long time. So I'm happy to take that.
You had a 4-hour lecture.
Yes. I was realizing I feel so, not rushed today. Okay, yeah, let me know because I'm going on longer than I probably should. Let's see, I forgot what I was talking about. Can you guys help me? What was I just talking about before we? The limitations of microcosting. Yes, so you don't factor in efficiencies because people are not necessarily going to factor in the time they took for breaks when they're thinking about time spent doing mailings or various activities. So in studies where they compared gross costing and microcosting, they've actually found that gross costing tends to be a higher estimate and microcosting tends to be a lower estimate. So it's kind of depends on what your priorities are for the analysis, which approach you take. Enhancing generalizability and usefulness. So in my teams, we generally use in the US, we have Bureau of Labor Statistics codes for different positions and salary levels, rather than using Dr. Rick Altice's salary specifically. We would use the salary of a physician. Of a physician in the US or in Connecticut, so that we create something that's a little bit more generalizable and can be used in other settings to estimate costs. And then finally, uncertainty is a big thing to think about in costs, because you never really have precision and certainty about your cost estimates, and so often you want to have a sense of what's the distribution of uncertainty around this estimate. So you'll, repeated measures prospectively collected are the best way to get at that uncertainty, but often in retrospective cost assessment, you're asking people to give you ranges or kind of a sense of the variation in time for various activities. So you can ultimately end up with some uncertainty intervals around your estimates when you do your simulations. We talked a little bit about costing perspectives already, so this is the viewpoint from which your cost effectiveness analysis is conducted, and this is incredibly important in grants and papers describing costing studies or cost effectiveness analyses to be very clear and explicate what was the perspective that you took when you collected these costs. Are you only focused on what the healthcare sector is, the cost the healthcare sector is incurring? Or are you thinking very holistically about the societal perspective, the time, the family spent coming in to clinic, the cost savings in terms of not having to miss work days, those sorts of things that may not be captured in the costs of the healthcare system, but are broader in impact. And the kind of current guidelines from the US panel on cost effectiveness analysis, and I believe kind of more local recommendations are to actually use 2 perspectives in cost effectiveness analyses, both the societal perspective and one other perspective, so they can kind of show that that impact of the societal perspective separately. The second U.S. panel on cost effectiveness came out with recommendations in 2016. It's a nice thick book, but there's also a nice summary in JAMA by Sanders et al. And one of the recommendations that I just talked about is this dual perspective, and then very detailed communication with your readers about exactly what went into your costing. This is a huge problem in the field of cost studies and cost effectiveness analysis, is that often people aren't very detailed in describing what went into their cost estimates. And so comparison between interventions becomes very challenging. If one study included societal costs and another study didn't, those two interventions could give you very misleading information if you just took them at face value. So the goal with a tool like this, where you specify kind of which sectors you're assessing, and within those sectors, what components you're including, can be incredibly helpful in helping with that issue. We talked about that perspective is better than retrospective in terms of rigor. One thing that I think is very interesting and important to consider, and I think someone yesterday asked a question kind of along these lines, is when does your costing strategy actually become part of your intervention? We sometimes think of this with fidelity assessments as well. When you cross over into like a quality assurance process that's a component of your intervention, the same can kind of happen with costing. If you're doing a lot of intensive tracking of people's time, you may or may not know how much that influenced behavior, and those top-down effects or observables that might actually promote fidelity. If you then go on to implement on large scale and you take this away, you might actually see a change in your implementation outcomes or effectiveness outcomes. So I think that's just something to keep in the back of your heads in designing this, and trying not to be too kind of obtrusive or interruptive in your approach. All right, and then we talked about this multi or mixed methods often are appropriate: surveys, interviews. Sometimes people do timed, like observation time studies. And then communication tools that can be quite helpful are cost narratives or tables that really just sort of outline exactly, what was measured, how many units, what did you, what references did you use to estimate various things, and that can be either in narrative form and in tables. So I'll end, because I wanted to make sure we had plenty of time for questions, by just kind of covering some take-home points. So I think we all hopefully are singing the same tune by the end of this conference, that effectiveness is necessary, but certainly not sufficient. And we had the session on implementation outcomes. If you have the most effective intervention, but very poor implementation, you might not even recognize that you have an effective intervention. And so effectiveness is necessary, but not sufficient. Costs matter in a world without unlimited resources. That's especially true for low and middle income countries. So economic evaluations can be incredibly important and helpful. Whether or not you propose an economic evaluation depends upon the state of the evidence regarding efficacy and effectiveness of your intervention. We talked about that. Keeping in mind, rigorous costing can be resource intensive. It's very helpful to engage. I think the last presentation had a fantastic image of a multidisciplinary team. I think I'm wondering if that was inspired by Leslie Curry's presentation of the kiwi that she tends to present. But thinking about a multidisciplinary team, this is what accountants do. This is what economists do. So getting someone on your team that can advise you and make sure that you're not missing things, or you have access to references on cost data that are reliable, can be incredibly helpful. Implementation studies should ideally include a budget impact analysis aim. If there's any doubt about availability of sufficient resources for scale out, the advantage of these of the BIA is that it can help with understanding investments needed to help decision makers assess feasibility. The downsides are that budget impact analysis results can be more difficult to publish in peer-reviewed journals due to generalizability concerns. I think that's always the case whenever you have kind of more descriptive study, just like qualitative work. It can be harder to publish these. If there's any reason to believe your intervention or program will be more costly than usual care, which is often the case, then a cost effectiveness analysis or a cost benefit analysis it may be appropriate. Cost-benefit analysis, keeping in mind the challenges around that, sort of monetizing certain health outcomes. The advantages, of course, the expected value of an intervention can help make the case with policymakers and payers that your intervention should be adopted and covered. The disadvantage of, and we talked about this, is that meaningful effects and benefit assessments might require complex methods like simulation modeling, which, we talked about how time intensive and costly just assessing costs can be. If you have a effectiveness outcome that really requires some projection out into the future or some complicated modeling, that can actually be even more time and more members of your team. And I put a bookmark there in case anyone was interested in simulation modeling, and we could talk a little bit more about that. Finally, remember that cost effectiveness is always relative to something. So if you remember one thing, I hope you'll remember that. Okay, I think we're done, and I think we just have a few minutes for questions if anyone has any.
I'll just ask a question because I'm sort of interested in this. When we're doing these implementation studies, and if we're keeping with the theme, better, faster, and cheaper, where this becomes the sort of analysis of this, do we oftentimes maybe perhaps give up a little bit of the effectiveness? We're doing it more efficiently with lower costs, where we can either be neutral with that so that you have an array of strategies that might actually end up being similarly cost effective, but have different outcomes in terms of like efficacy. I mean, and do the people who make societal decisions about whether to fund A and B as opposed to A or B, do they often use that?
Yeah, those are the two very good questions that probably have different answers. And you're absolutely right. The optimal decision might be to choose a less effective intervention if it's more, if it's lower cost substantially, especially if you're have a limited budget and resources. The second question as to whether decision makers actually do that or use that, I think it is very nation to nation, health system to health system dependent and variable. So there are, certain countries that spend a lot of time thinking about cost effectiveness, like the UK. They have a whole, the NICE group is, focused on cost effectiveness and assessing kind of differences. I think the US is an example of a lot of ad hoc decision making and not necessarily being guided by cost effectiveness. We have very costly interventions that don't necessarily improve quality adjusted life years very much that are covered, and then we have other interventions that substantially improve quality of life and life years that are uncovered. So I think, there's a lot of variability there.
And then I just wondered, the follow-up question to that is, so if you have, let's say, from a societal perspective, let's say we choose as a society that we're willing to spend $150,000 for just like let's say dialysis or something like that, or anticoagulation for atrial fibrillation, and we're willing to sort of spend this. Do we have any implementation studies to help guide the people who make these decisions about these, cost-effective interventions relative to each other in terms of making some decisions? Because some things are really much, much more cost-effective, if you will, from a societal input, but yet they don't get adopted in the payment system.
Yes, exactly. And so I think that is exactly what cost-effectiveness analysis is meant to do, is to compare these different strategies. So I briefly mentioned this kind of choices project where it's a childhood obesity cost-effectiveness analysis project where essentially I think the paper I published at the time I published, there were 13 different interventions for childhood obesity that we kind of compared with each other in terms of their costs and their impacts on obesity prevalence. And so just being able to kind of look at those next to each other and sort of assess potential impact. You know, I believe there are 3 or 4 interventions that were cost saving, like the sugar taxes and having physical activity at schools and things like that. But then you also, so the important thing I want to say is that we shouldn't narrowly focus on on the ICER or the cost effectiveness claim either, right? Because then we get challenged by equity issues. So in the study that I did, we were looking at treatment interventions alongside prevention interventions, and treatment is never going to be cost effective compared with prevention. But we have to have treatment for people who are affected by health conditions. And so you have to kind of pull things apart and kind of look at them in those groupings to make sure that you don't get lost in the sea of ICERs. And so I think your point is a really good one that, you know, I think there was points in time in the history of cost effectiveness analysis where people thought you could just dump everything into, you know, all health conditions. If you get them to quality of just life here, we can just choose the interventions that yield the most quality of just life years for the lowest cost. But the equity implications, I think, are really huge and challenging, and we can't do that. We have to actually kind of look within conditions and consider different populations and different health conditions.
Mona, you mentioned the UK does a lot of medical care. Given that healthcare costs differ so much from one country to another, how much can we infer there is in here, let's say America shows amazing cost effectiveness for X? How much can you infer that it's going to be the same for your country rather than go through that motion all the way?
That is such a good question, and I had a point on one of the slides about kind of generalizability, and so I think that there is this push with this second US panel to get people to be discrete and descriptive with costs at a level where you could look, and as a decision maker, you could look at each line item included in the table of costs and say, well, I don't expect, you know, community health workers in my country to need to spend as much time in X, Y, and Z, or I would expect them to spend more time. You could kind of look at that level, and you could look at the salary estimates and change them over to the appropriate salary estimates for your country. And so I think that it wouldn't be, of course, it's not going to be directly translatable, but if we have more discrete and descriptive cost information, then you might be able to get close to an understanding of what would be needed in your particular setting where you're trying to decide whether to implement or not. All right. Well, thank you guys. I can't thank you enough for paying attention to other afternoon on other